And it's my great pleasure to introduce to you a powerhouse who is going to be sharing her presentation. And I love this. And it's called Pills, Patches, and Rings. Oh, my. So I know it's early in the morning for humor, but I think that she's going to have a great presentation for you about this very impactful concept. And it's my pleasure to introduce Alyssa Long. Alyssa is an assistant professor of pharmacy practice and administration at the University of St. Joseph School of Pharmacy and physician assisted studies in Hartford. Does that all fit on a business card? No. Okay. So she graduated from Western New England University College of Pharmacy and Health Sciences in 2019. And she's completed a postgraduate residency at UConn John Dempsey Hospital and a second-year residency in ambulatory care and academia at Veterans Health Indiana and Butler University. After completing her residencies, Alyssa transitioned into the role of assistant professor of pharmacy practice at Massachusetts College of Pharmacy and Health Sciences in Boston before joining the USI faculty in 2023. She's a member of the CPA Board of Directors, and she chairs the CPA Membership Committee. Alyssa, please give her a round of applause.
Okay, hi everyone. Thank you for that introduction, Lieutenant Governor. We have that. Okay, so today we're going to be talking about pills, patches, and rings. Oh my. So we're going to be talking about hormonal prescription. And I have the objectives here. I'm not going to read them off to you. You can see them on the lecture panda. Same with the pharmacy technician objectives. So we're going to go straight into it. I have nothing to disclose. How confident do people feel about prescribing hormonal contraception right now before we get started? So who's feeling not confident at all? Okay, so we got a lot of not confident at all. What about somewhat confident? No somewhat. What do we got? Confident. Very confident. Okay, so this will be good. We'll start right at the beginning. And we kind of went over the reason why we're talking about this. So for the sake of time, we'll just kind of pass by this. I'm sure everyone knows that contraception is the prevention of pregnancy. But the way we can go about that is by multiple different mechanisms of action, whether we're using non-hormonal contraception, hormonal contraception, which can be combined hormonal or progesterone only. So our non-hormonal contraception really works by physically blocking the passage of sperm or blocking the ovaries themselves. Our hormonal contraception works by inhibiting ovulation. The progesterone only also has the ability to interrupt implantation of an ovum as well. And then there's different ways that you can define effectiveness. And for us, we really care about the typical use effectiveness. That's what we're going to be telling our patients about, because that means the typical patient, the effectiveness of them using that contraception. So that's what we really care about. Perfect use is ideal, but we're never going to see that in real life. Does this look familiar? The menstrual cycle, bringing PTSD back from pharmacy school. So before we even get into this image, we're thinking about the negative feedback loop. That's really what hormonal contraception is targeting. So we have the hypothalamus, which isn't in this picture, secreting gonadotropin-releasing hormone. That then binds to the pituitary gland receptors, tells the pituitary gland to release FSH and LH, your follicle-stimulating hormone, and your luteinizing hormone. Those then get secreted, bind to receptors on the ovaries, tell the ovaries to secrete estrogen and progesterone. When you have high enough levels of estrogen and progesterone, they go back to the hypothalamus and say, stop doing what you were just doing. And that is your negative feedback loop that we're trying to target. The reason I included this picture is because this is what we're thinking about when patients are on hormonal contraception, where the side effects are going to come from. So if we're looking at this photo, you can see here, and we have two different phases. We have our follicular phase. This is what I tell the students, F for first. And then we have our luteal phase, L for last. So our first phase is follicular, last phase is luteal. In our follicular phase, this is where we have our estrogen starting to become more prominent, and it's helping build up the endometrium. Then we are maturing the follicle, getting ready for that LH surge that occurs with ovulation. You have this LH surge where your egg comes out of the follicle. And then you go into your last phase, your luteal phase. You still have estrogen, but you have the more predominant progesterone in your last phase. And progesterone is helping maintain that endometrium and getting it ready for implantation. This is going to be important when we're thinking about breakthrough bleeding and things like that when you're having patients on this for side effects. This is a very busy slide. The only thing that pharmacists have the scope to prescribe currently is our combined hormonal contraceptions, our oral, our transdermal patch, and then the vaginal ring, as well as the progestin-only pills. It's still really important to understand the non-hormonal methods. For the sake of time, I'm not going to be able to go into those today. But when we start patients on hormonal contraception, we're going to talk about backup methods. Our non-hormonal methods are our backups. Typically, patients are going to use these barrier methods with the male or female condoms, but there's a lot of different options for patients, and it's important to be aware of them as well. Same with our progestin-only contraceptives that aren't bolded. The implanted rod or the subdermal implant Nexplanon, and then your IUDs have the highest typical use efficacy. They're becoming more popular with providers and patients alike. So it's important to be aware of these in case patients are interested in them. You can give them information about it and then refer them to the providers to get the prescription and administration. So I like to do the PPCP process. I find that's a good way to kind of summarize everything we're going to talk about before we get into the thick of things. So the way that we're thinking about approaching prescribing hormonal contraception, we're going to collect patient information. And that's everything that we can: past medical history, medication list, have they used hormonal contraception before, what side effects did they have, what social history do they have, and then patient preferences. Do they prefer a specific formulation? Are they trying to avoid a certain side effect? Do they want a really fast return to fertility, or do they want to prevent pregnancy and not get pregnant for many years? And when we get all of that information, then we're going to assess it, as well as trying to assess immunization status. Is our patient due for any key immunizations? And then disease state screening. Do our patients need to be referred for pap smears or mammograms? Going into the plan, once you assess everything and say, okay, these are our options, you'll discuss that with your patient and you share decision making to decide what medication to actually go forward with. You pick that medication, you'll counsel your patient on it and implement. You'll prescribe and dispense that medication. You're going to document everything, and then you're going to notify the PCP. This is what I anticipate follow-up being. The regulations aren't out currently, so it could be a little bit different. Based off of us waiting 3 months to see how side effects go, I would anticipate it would be recommended that we would follow up in 3 months to assess tolerance and adherence. So now we're going to get into it. So we're going to start with our combined hormonal contraceptives. These are the ones that contain both estrogen and progesterone. There's multiple formulations. There's the pills, patches, and rings. Oh my. And mechanism of action is suppressing the ovulation through the negative feedback loop. The typical failure rate for this is 7%, according to the CDC. Some studies have shown it can go up to 9% typical failure rate, but right now counseling patients on that 7% is perfectly fine. The reasonable return to fertility is about 3 months, so consider that when you're hearing about what patients want when they want to get pregnant if they're interested. And then there are some products, mainly the pills, that have additional indications for the treatment of acne, premenstrual dysphoric disorder, and heavy menstrual bleeding or menorrhagia. These are all of the different products we get to choose from. So estrogen has a lot less variability. So ethinyl estradiol is going to be your main estrogen in your combined hormonal contraceptives. Estradiol valerate is a newer one that we see in a quadriphasic pill. And then has anybody heard of estratrol? It's really interesting. It's a plant-based estrogen. There's a ton of progesterones. We're going to go into that when we go into progestins by themselves as a component, and we'll go into how they're different. So first, we're going to go into what estrogen is. So this is working specifically on suppressing FSH. When you don't have follicles developing, you're not going to have an egg erupting, so you're not going to have ovulation. Estrogen also has the benefit of having that sex hormone binding globulin. So it's going to bind free androgens, which will help with acne and hirsutism. So most patients that are on estrogen already are getting some benefit for acne. On the flip side, it also increases aldosterone levels. So that's water, sodium retention. So you're going to get some weight gain. Then the dosing. Estrogen dosing is a little bit different than what we see with other disease states where you get a medication, you start low, and you titrate up slowly. This one, we're really going to look at 35 mics and less. And there's no clear guidelines on where you have to start. Some studies recommend if patients are underweight or normal weight, you'll start with the 10 to 25 mics. And if they're overweight to obese, you would go the 30 to 35. It's not the end all be all. You don't have to do that. Other ways that you could approach this is that if patients have breakthrough bleeding just regularly in their cycle before being on hormonal contraceptive, you would start with that 30 to 35. We're really not going to see the 50 microgram dose. This is really from older studies where it was thought that you need a higher dose of estrogen to suppress ovulation, which is not the case. We can suppress ovulation with 10 micrograms. So really, we're going to see that 10 to 35 range, and we'll see how we can adjust based off of side effects next. So really, when we're thinking about patient side effects, estrogen's most common side effect is going to be nausea. There's ways that we can help patients minimize the nausea before even doing any dose adjustments. So we could tell patients to take their birth control at night. We can tell them to take it with food. And after 3 cycles, if they're still experiencing nausea, we know that's caused by too much estrogen. We could either lower the estrogen or switch to a different formulation. The other really common side effects of too much estrogen is that bloating and breast tenderness, headache, and the heavy menses. The big one for not enough estrogen is that breakthrough bleeding early in the cycle, which goes back to the menstrual cycle. Estrogen's more prominent in that follicular phase. You don't have enough estrogen for that follicular phase, you're going to have some bleeding because you're not being able to maintain and build up that endometrium. Going into the progestins. So progestin mainly works by preventing that LH surge, but progesterones also have a benefit of thickening the cervical mucus, which will prevent sperm from actually being able to travel to the ovaries. They also cause atrophy of endometrial lining and then decreasing the motility of the ovum. So this means that if somehow a patient is on hormonal contraception and get pregnant and they're on a progestin mechanism, there is a chance for ectopic pregnancy because they're not able to actually have the egg travel from the ovaries all the way to the endometrium to get implanted. So just something to be aware of. And then with the progestins, we're really thinking less about dosing like we are with estrogens and thinking more about the generation of the progesterone. The first generation of progesterones is our oldest, and they were very nonspecific. So they bound to steroid receptors, whether that was progesterone receptors, glucocorticoid receptors, or just androgen receptors. Because of that, more side effects. The second and third generation were created to have less androgenic side effects. And the fourth generation has some key special ones, like drospirenone is an anti-androgen and anti-mineralocorticoid properties. So less of those side effects. It should actually help with acne, help with any hirsutism, and kind of actually treat those. Dianogest has no androgenic properties whatsoever, so it would be good, but maybe not as much treatment. And progesterone is just a fourth generation. So when we're talking about androgenic, we're thinking acne, hirsutism, maybe some weight gain, hair loss, and then swelling. We can go into the dosing a little bit with our too much versus not enough progesterone. The too much progesterone is really going to be that androgen excess. Not enough is going to be that breakthrough bleeding late in the cycle, right? Because progesterone is more prominent in your luteal phase. It's maintaining the endometrium. If you don't have enough in your luteal phase, you're going to have your endometrium breaking down and having that breakthrough bleeding. And I'm sure this is what everyone's been waiting to hear about, the thrombosis risk with combined hormonal contraception. So we're going to tell our patients about VTE risk, but to give you some background about why we're worried about VTE with hormonal contraception is actually because when estrogen goes through first pass metabolism, it causes increased production of clotting factors in the liver. When you have increased clotting factors, you're more likely to have a VTE. This has been found to be a dose-dependent risk. So if you do have a patient that you're really worried about VTE, but they don't have any contraindications to getting combined hormonal contraception, maybe we go with a 10 microgram dose because we see from the data here, there's almost a 50% decrease when you go from that 50 microgram dose to the 20 microgram dose. There is also some evidence, it's not the end-all be-all evidence, that the third generation and fourth generation progesterones increase the risk of VTE as well. There was a Cochrane review that showed compared to the second generation, there was a 50% increase of VTE risk with the third and fourth gen progesterones. Thinking about thrombosis risk, we're not just thinking about VTEs, we're also thinking about strokes and heart attacks. There is a slightly higher risk for patients on combined hormonal contraception with strokes and heart attacks. That being said, it is still less than the risk of patients with hypertension or the risk of patients that smoke. So it's just trying to think about these things, especially when we're talking to our patients, to really put it in perspective for them and educate them without scaring them. I'm not sure how well everyone can see this in the back. So with this, I find this is a really helpful diagram from a review article about the VTE risk with combined hormonal contraception that breaks it down. The top is your least risk, the bottom is your lowest risk. So your combined oral contraceptives with fourth generation drospirenone has the highest risk of VTE. Your progestin only options have the lowest risk. And then we have our kind of first, second gen in the middle. So that's how this is something I think could be really helpful when we're thinking about prescribing and trying to pick agents depending on patients' risks. This could be a really helpful image for you. We have the background on VTE risk now. So what are we going to tell our patients? We want to educate them on the signs and symptoms, but we also don't want to scare them. So we're going to tell them about the signs and symptoms to watch out for, and then we're going to tell them about the overall risk. The signs and symptoms that we look for are the aches. And this isn't just VTE, it's kind of thrombosis in general. So we have abdominal pain, chest pain, headache, eye problems, and severe leg pain. So that really covers your VTE, your stroke, and your heart attack. Then we're also thinking about the risk compared to pregnancy or postpartum. The whole point of taking combined hormonal contraception is to prevent pregnancy. So if you do get pregnant, your risk of VTE is higher. And if you have your baby, your time afterwards, your postpartum, is a higher risk of VTE as well. So the risk of having a VTE on combined hormonal contraception is still less than if you were to get pregnant. So it's kind of helping you prevent getting pregnant, but also lowering your risk from that perspective. So I like to use this image when I'm talking to my patients so they can visually see what I'm talking about. And then hopefully they will feel less stressed out about the VTE risk. Moving on to the drug interactions, estrogens are CYP3A4 substrates, which means that there are a ton of interactions. When we're thinking about inhibiting CYP3A4, that means that you are increasing your estrogen, increasing the risk of side effects, increasing your VTE risk. If you have CYP3A4 inducers, they are increasing your risk of pregnancy. Progesterones are metabolized by a lot of hepatic enzymes, so more drug-drug interactions. Really, we're still focused on the CYP3A4 with the progesterones as well. Other mechanisms to consider is the GI absorption and then any intestinal mobility that can be affected by bacteria. And then there's the broad spectrum antibiotics. I'm sure everybody is used to whenever a patient that has birth control on their chart that gets an antibiotic, just counseling them and telling them to use backup method. More recently, there have been some reviews that have shown that the decrease in ethanol estradiol is not as much as it was thought to be. However, we're probably still going to tell our patients to use backup method. So the specific medications that we care about are anticonvulsants and our neurologics, our phenytoin, our carbamazepine, lamotrigine, topiramate, all of our CYP3A4 inducers. There are some oncology agents that are contraindicated, and then we're looking at specific antimicrobial agents that have a lot of CYP involvement, like your rifampin, your HIV antiretrovirals. This is all also on a document I'm going to show you later on that basically tell you that if patients are on these medications, we're going to refer them out anyway. So if we do have patients that are on medications that are short-term drug-drug interactions, what do? They can stay on the hormonal birth control, and then they'll also use backup method during the time that they are on that medication. If they're on it for a long-term use, then you could consider increasing to the 50 microgram dose. However, if they're on long-term use at that point, I would most likely refer to their PCP and have them manage the hormonal contraception as they see fit. And then ultimately with our broad spectrum antibiotics, the recommendation is that they continue with a backup treatment plus at least a week after they finish their antibiotic using that backup. So going into the contraindications of combined hormonal contraception, there is the United States medical eligibility criteria that according to the current legislation, all pharmacists must review before prescribing birth control. And they basically break down the eligibility of patients based off of different characteristics. They color code it as well as number it. So 1 through 2 is most likely what we're going to be able to prescribe for. We don't have clear guidance yet However, based off of what the prescribing patterns have been in other states, which I anticipate we'll see here, 3s and 4s usually generate a referral to a specialty provider. So 1 is you're good to go, 2 is benefits outweigh risks, 3 is risks outweigh benefits, and 4 is don't use. This is the image. It's very busy. That's 2 pages, so it's just a screenshot from 1 page. But if we break it down, it's not too bad. So we can see the first one is the condition. So it's any type of, they even have age, they have obesity, there's medications that are listed on this, but you have your condition here. Then you have your subcondition. So for example, for breast disease, you have breast disease as your condition. Your subcondition can be family history of breast cancer that you have, whether that's current or past, and then they break it down from there. Then we look over another column. This is your copper IUD, so this is non-hormonal. The levonorgestrel IUD, we cannot prescribe this one. The subdermal implant, again, we cannot prescribe. The depot-medroxyprogesterone acetate is the injection. And then the 2 that we would really be looking at are the progestin-only pill and the combined hormonal contraceptives. Okay. And then we go down a row and you see these I's and C's. There's actually no key for the I's and C's. So I have a nurse practitioner friend who I went to and I was like, what do these I's and C's mean? And I is initiate and C is continue. So there's not many you can see here for cervical cancer. You would not initiate, but you could continue if a patient is on the copper IUD and then they get cervical cancer, you could continue them on the copper IUD. And then we have one more other thing to consider that you can see here, that malabsorption for combined oral contraceptives are a 3, but you have this P/R. Again, no key. The P is patch and the R is ring. So obviously those are not going to go through your GI tract. So those are okay to use when you have malabsorption through the GI tract. So that is how you would read this. The asterisks are under advisement. So basically how you feel about it. So if we go through this and we look at our first 4s for both our progestin-only pill and your combined hormonal contraception, the first one would be current breast cancer. And even the past breast cancer are 3s. So most likely these patients would be we would not be able to prescribe for them in the community setting. Hopefully that makes sense to everyone, how to read this chart. I'm not going to go through this entire list, but I did want to go through some of the 3s and 4s and explain why they're 3s and 4s. Breast cancer, it's a hormone-dependent disease, so you do not want to be giving estrogen and progesterone. Breastfeeding. So breastfeeding is specifically because of the estrogen component. Estrogen decreases milk supply, so we're not going to be giving estrogen while breastfeeding, at least in the first 6 weeks. Then you have postpartum less than 21 days and not breastfeeding. It goes back to that image we talked about. Patients that are postpartum are at really high risk for VTE. We don't want to give them a medication that would increase their risk further. Looking at migraine with aura, this is going to be a really big one to screen, especially for younger patients that have migraines, really clarifying how their migraines present because they might not realize it's with aura. And this is because patients that have migraine with aura are at higher risk for stroke. So then if you add in estrogen, you're increasing their risk for stroke further. Looking at the blood pressure, the estrogen increases blood pressure. So if you have patients that have elevated blood pressure, you're going to elevate their blood pressure further. So those most likely are going to be referred out to ensure they're being followed properly. Thrombogenic mutations increase your risk of thrombosis. And then the smoking and greater than 35 years old. This is because of the estrogen component increasing the risk of stroke. So now we're actually going to go into the formulations now that we've gone through all the background of the combined hormonal contraceptions. We're going to start off with our combined oral contraceptives or our COCs. You'll also learn that Women's Health has a very large amount of acronyms. So COCs, you've probably seen this. They come in the little packs, either 21 active pills, 7 placebo pills, 24 active pills, 4 placebo pills. The difference between the different regimens, we have our monophasic, biphasic, triphasic, and quadriphasics. All this is the different amount of estrogen and progesterone to better mimic the menstrual cycle. The biphasic, triphasic, and quadriphasic, it was thought that if you better mimicked the menstrual cycle, it would have better prevention of pregnancy. That's not really the case. It really kind of changes your side effects. So if your hormones are changing regularly, you're going to have more likely to have mood changes and breakthrough bleeding. I have asterisks next to the monophasic and triphasic because those are the most commonly prescribed ones. Then we have our extended regimens where you have 3 months, so 84 active tablets with 7 placebo tabs. So patients are only having a withdrawal bleed 4 times a year rather than 12 times a year. Or you could do a 1-year continuous cycle off label. This is where I'm going to go on my soapbox for a second. Withdrawal bleeds are not physiologically necessary. You do not have to have a withdrawal bleed if you do not want to. So if patients are on monophasic contraception, it is okay to skip the placebo pills and continue with active pills. That is if patients have a normal cycle before they initiate. If they have any type of abnormal uterine bleeding, if they have breakthrough bleeding during cycles regularly, you're not going to suggest continuous, but it is okay. It is safe in patients. So that's my soapbox. And then there is a chewable tablet formulation. I feel like a lot of people don't know this. This is ethinyl estradiol 25 and norethindrone 0.8. With the chewable tablet, you just want to tell patients to make sure that after they chew it, to have a glass of water to make sure there's no remnants left in the mouth. It tastes like mint. These are the different regimens just in picture format. I do not have time to go into all of the different regimens available for you to prescribe from and to choose. So what I did do was include the pharmacist letter in Lecture Panda from February 2023 that has a huge list. And really what you're going to think about when you're choosing a product is going back to our background. What dose of estrogen do we want? Is there a specific progesterone do we want? Do we want monophasic or biphasic or any of the different regimens based off of how our patient's presenting? And then you can consult that list and consults the patient's insurance, and that's how you end up prescribing. So once you figure out which product you're going to choose, most likely what's going to happen and what I anticipate the regulations saying is that you're going to have the quick start. A lot of the other states say quick start's the only option. I wanted to give you all of the options. So Sunday start just means that the patient takes it on Sunday. That's because if we go back, all of these pill packs have the Sunday. The patients have stickers that they can put whatever date they actually start here, but the Sunday start is just because this says Sunday on the packs when they get them. If they do the Sunday start, they'll have to use backup for 7 days. You could do the same day start where you start at the same day as the patient's menses. This way they wouldn't need to use backup. It gives the patient enough time to get the hormones into their system. Or you do the quick start, which is what a lot of the other states' regs have, which is that you see that patient, you tell them to start it that day and to use backup method for 7 days. So now they've started it. Most likely we're going to follow up in 3 months because we want the patient to have an adequate trial, which is 3 months. It takes about 3 months for the patient to get used to the hormones that they're taking. So if they come back to you in 1 month and say, oh, I have such bad nausea, we can recommend those lifestyle changes, but we're not going to change the dose yet. We want it to get into their system properly. If they're doing the lifestyle changes and 3 months later they still have nausea, that's when we're going to take action and try and decrease the estrogen dose because we know that falls in the too much estrogen column and see if we can decrease and help manage that side effect. So if the patient does have any serious side effects, we're going to stop the COC even before 3 months. And then missed dose management, this is the one formulation I can't give you an exact answer because there's so much variation in this formulation. So really you're going to check the phase. And then also just the package insert for whatever brand it is most likely where you're going to have to give a recommendation on missed dose management. Those are our COCs. We're going to go on to the transdermal patch now. We have 2 real options here, the Xulane, Zafemi, which are kind of branded generics, and then our Twirla, which is the new one. You can see here they have a similar amount of ethinyl estradiol, 35 versus 30, so falls in that same category of dosing. The real difference is the progesterone. So our Xulane Zafemi has a 3rd generation, whereas Twirla has a 2nd generation. The other difference is that Twirla is a bigger patch. They're looking at the side effects reported in the clinical trials. Twirla overall has lower incidence generally, besides it does have higher breakthrough bleeding. So that could be a way you could choose. Also insurance. And then when you are recommending this for a patient, making sure that they apply the patch appropriately. The patch is a once weekly patch. So you're going to switch your patch weekly for 3 weeks and then take that patch off and have that withdrawal bleed week. Off label, if patients are safe to do so, you could just apply a new patch and do continuous. Patients can keep the patch on when they are showering, swimming, or exercising. You're going to counsel on side effects. So it's all the side effects we talked about in that combined hormonal contraception background. And then also additionally, we're going to counsel them on patch side effects such as skin irritation. There is studies that have shown that it's less efficacious in patients that weigh 90 kilograms or more. This is not a contraindication according to USMEC. USMEC does not include weight as a reason to choose one over the other. This is something that, since we have the ability to choose multiple options, that we would definitely want to counsel our patients on and make them aware of it, especially since we have that information. And because it's once weekly, we could consider it for patients that struggle with the daily regimen. Initiation of the patch is the same as the combined oral. So you have the Sunday start, the first day, or the same day, and then your quick start. Most likely we'll do quick start. And then if you're switching from one combined hormonal contraception to this formulation, it's basically the same thing. So if patients have a withdrawal bleed, they don't need backup. If they're in the middle of, say it's a pill, then you'll just tell them to use backup for 7 days when they switch to this. We also have to consider that patches fall off. So what do we do when patches fall off? So about 5% of patients have patches that fall off, which is pretty low considering I would have anticipated it to be higher. So if a patch does fall off and it's less than 24 hours, they can just put on a new patch. If it's more than 24 hours, this is where it gets a little bit complicated. So when I think about this for choosing a patch, you really want to make sure you're explaining cycles appropriately. So if you are in cycle weeks 2 or 3, you're in the middle of your cycle. If your patch falls off for more than a day in the middle of your cycle, you're going to apply a new patch and you're basically starting a new cycle. So you're starting back at week 1. You're no longer in that week 2 or 3. So that means you're going back to week 1 and then doing 3 weeks continuous, even if you've done 2 weeks continuous or 3 weeks continuous before that. Missed doses in general, so not just that it falls off. If you forget, you go through your withdrawal week and then you don't put it on right away. When you remember, put it on and use backup for 7 days. If you're in the middle of the patch cycle, so when you need to apply for weeks 2 or 3, if it's forgotten for that greater than the 24 hours, that's when we're going to do that new cycle again. So just really explaining what the new cycle means to patients. Moving on to the vaginal ring. We have 2 options here. We have NuvaRing and Annovera. NuvaRing has been around longer than Annovera. Annovera is the newer option. You can see the similar amounts of ethinyl estradiol. The difference is in the progesterone again. Annovera is a 4th generation. NuvaRing is a 3rd generation. Both rings are inserted intravaginally and they stay in the vagina for 3 weeks. So it is very easy for patients to use. They insert it and then they're good for 3 weeks. Off-label, it can stay in for 4 weeks. So for Annovera, it can be used for up to 13 cycles. So you would just leave it in. For NuvaRing, you would just put in the new ring on that week 4. So that is the difference between your NuvaRing and Annovera. Is NuvaRing, you have to change your ring each cycle. Annovera is you can use the same ring for 13 weeks. So when you are removing it or inserting it, you just clean it with mild soap and water and then pat it dry and you store it in your case and then you're good to use it again. It doesn't even need to be refrigerated in between uses. If you are using that off-label continuously, you just have to make sure you talk to your patient about the cycles and do that math correctly. So this is a really good option for patients who struggle with daily regimens or the weekly regimen. You're still counseling your patient on those CHC side effects that we already talked about. We're also going to add in additional side effects, so it can cause vaginal irritation or dryness. We also have to consider how to administer it. So for administration, you want your patients to wash their hands with soap and water beforehand. They want to remove the ring from the packaging. The NuvaRing, you want them to keep that packaging for when they're going to throw it out. So you want to counsel them on that. Then your patient should get into a position similar to how they're inserting a tampon. They'll squeeze the ring. It's a really small ring. It's very flexible. So they'll just kind of squeeze it on the sides and then they'll be able to insert it. You want to tell your patient once it's inserted, as long as they can walk around and they don't feel it, they're good to go. If they're feeling it while they're walking around, they should stop, get into that position again, and then try and move it around or insert it deeper if they can. There are some really good videos that I had my students find so they got more comfortable with it. So there are really good videos that you could use when you're counseling patients on how to administer it as well. The ring can stay inserted during any physical or sexual activities, and you want to counsel your patient not to do any vaginal douching. This should really be stated for all of our patients, but we definitely don't want it with the ring. When they're ready to remove it, they can hook their finger and pull it out. For Anavera, you're going to clean it and store it. For NuvaRing, you want to go back to that packaging they saved and then throw it in the trash. For our rings misdose management, it is a little bit harder to remember because they have different time cutoffs. So our NuvaRing is 3 hours and our Anavera is 2 hours. If your ring is out for less than that time, they can clean and reinsert the ring. If they have it out for more than that 3 hour or 2 hour cutoff, then they can clean and reinsert the ring, and they have to use backup for the 7 days. This is a summary that we're going to bypass for the sake of time. And going into the progestin-only contraceptives, some background about this, we've gone over the formulations. The mechanism of action is the same as that progesterone mechanism of action that we talked about just as a CHC component. Really, when you see this with prescribers, a lot of prescribers are going to go to CHC before progestin only. They're really going to use progestin only for patients that can't use CHCs. So you still have some contraindications that apply to CHCs, apply to progestins, really breast cancer, liver disease, things like that. These are really good for patients where estrogen is the reason we can't use CHCs. So patients that have high blood pressure, patients that are breastfeeding, patients that have smoke and are older than 35 years old. So all of those are patients that when we're doing our assessment, we're like, okay, we're going to go the pill, the progestin-only pill for these patients. We have 2 options here. We have norethindrone, which you might have heard of as the mini pill. This is generic. And then we also have drospirenone, which is newer. It was FDA approved in 2019. It is only brand. The difference between the two is the leeway with adherence. So I'm sure you guys are familiar that when you think of progestin-only pill, you're thinking, okay, they have to be very adherent with a progestin-only pill. This is because if you have a 3-hour window that you have to take your norethindrone. So if you're outside of that 3-hour window, the patients need to take it as soon as they remember and use backup for at least 2 days. Norethindrone doesn't have any placebo tablets, so it's active all the time. And it does have a slightly higher typical use failure rate than drospirenone. Drospirenone has some placebo tablets, so it's 24 days active, 4 days placebo. And it has more wiggle room for if you forget a dose. So you have 24 hours instead of 3 hours to remember to take your missed dose. So if you miss 1 dose, you can take it as soon as you remember, and you do not need any backup. If you miss 2 doses or more, then you're going to take it as soon as you remember and use backup contraception for 7 days. So norethindrone is really that one that you have to remember the 3 hours and backup method for 2 days instead of that 7. Some considerations, again, weight is not a US MEC contraindication, but there has been some evidence that the norethindrone pill is less efficacious in patients that weigh more than 70 kilograms. Something to take into consideration if we have other options that will be covered by insurance for our patients. Also counseling our patients on ectopic pregnancies. Norethindrone, when we're thinking about choosing between the 2 options, it is 1st generation. Drospirenone is 4th generation. So norethindrone is going to have more of those androgenic side effects. Drospirenone weirdly has a side effect of hyperkalemia. So just thinking about that, considering what other medications our patients are on. Our drug-drug interactions are basically the same thing that we're thinking about with our combined hormonal contraception, except drospirenone, now we're thinking about potassium-sparing diuretics, we're thinking about Bactrim, we're thinking about ACEs and ARBs. But we do not have to worry about the broad-spectrum antibiotics with the progestins only because they impact the estrogen, not the progesterone. This is this summary that we're going to bypass. So now we're going to summarize it. So for wrapping it up, when we're screening, we're looking at past medical history. We're thinking about medication lists. We're thinking about possibly weight, social history, pregnancy status, blood pressure, and then any patient preferences. When we're counseling, we're going to verbally counsel, but we're going to provide educational written material for the patient to take with them. And then we want to talk about prevention of STIs. Hormonal contraception is not going to protect patients from STIs. So we really want to emphasize that. We are going to need to document and keep records of all of this interaction. And then we do have to notify the PCP. And then monitoring, this is what I anticipate based off of other states' regs, so that you do usually have to have a new screening document every year. And I anticipate following up in 3 months for that tolerance. This is an algorithm from the Washington State Association where you can see you're doing your screening document. If they have any of those 3 or 4 contraindications, you're going to refer. Then you're going to do this pregnancy screen, which is straight from CDC. And as long as they can answer yes to one of those questions, then you're good to say, okay, you're not pregnant. And then you can go forward with your visit. This is another image from the Washington State Association, which kind of summarizes everything I had in a bunch of different slides. So you've got disease states, you've got side effects, and then how you would manage based off of dosing and different formulations. I don't have enough time to talk about emergency contraception, but that is something that we can now prescribe. So with that, I just want to do a brief overview. Copper IUD has the highest efficacy for emergency contraception. Patients would need to be able to get to a provider within 5 days to get that inserted, which might be a little bit difficult. The Yatsby method is doubling hormonal birth control. It has the lowest efficacy and the highest rate of nausea. So patients typically vomit on that. So probably not our best option. So what we're going to be talking about is the ulipristal acetate or ELA and then levonorgestrel. So levonorgestrel is our OTC option. FDA states that you should use it within 3 days. There are some studies off label that have shown that there is efficacy at 4 and 5 days. It's just less efficacious. And then once patients take the levonorgestrel, they're okay to continue on their typical contraceptive method. There is studies that have shown that reduced efficacy at weight greater than 165, though it's not on the package because the FDA ruled there wasn't enough evidence. What I tell my students in class is this is the only option. Lower efficacy in days 4 and 5 and lower efficacy at weight greater than 165 is better than no efficacy and then getting pregnant if that's not the patient's wish. Now that pharmacists can prescribe, that might be where we look at ELA because ELA has the approval for up to 5 days, has higher efficacy than levonorgestrel at that 4 and 5 day mark, and has the reduced efficacy at a higher weight than what you see with levonorgestrel. The one caveat for ulipristal acetate is that it binds to the progesterone receptor and prevents progesterone from getting in there. So patients that are on hormonal contraception, they're not going to work as well because they can't bind to the progesterone receptors. So typically you have to wait 5 days after using the ulipristal acetate to restart your hormonal contraception. And if patients actually need emergency contraception again in the same month, it's recommended that they only use ulipristal acetate. So just be aware of those caveats when you're counseling patients on that. For the bill requirements, this is what we have available of what needs to be done currently. So pharmacists complete an educational training program. You're all here. Reviewing the US MEC beforehand, so hopefully you'll be able to decode the 2 pages now a little bit easier. Completing a patient screening document, which most likely we will be provided, and then keep that documentation for 3 years. Prescribe up to a 12-month supply, and then counseling and notifying the PCP. For pharmacy technicians, educational program, providing the patient screening document, taking and recording blood pressures, and then intaking patients' past medical history. I anticipate that they'll be really helpful for getting those key questions we need answered about the past medical history, because we really want to hone in on some of the background and the kind of the HPI of those past medical history to really rule in or rule out different formulations. I was excited and hopeful that I would have things to tell you, but we have keep an eye out. Oh, the questions are here, but they have the answers. Okay. I mean, I know them pretty well. Can I just verbally do them? share? Do we want window? And then the PowerPoint? Okay. I know them well, but I don't know the words. So they're going to be the key things that I need you guys to know. So we have a patient who is on the norethindrone tablet. She usually takes it at 5 a.m. She calls the pharmacy at 9 a.m. saying she forgot to take it. So what actions are we going to tell her to take about her missed dose? So first, we'll go, can she take a pill as soon as she remembers? Yes or no? Yes. Does she need backup? Yes or no? Okay, so we've got yeses and nos. So for this, she will need backup because it's norethindrone. What's the time frame for norethindrone? 3 hours. Some other key things to take away from that question, I think I had that she was breastfeeding. So even when you might not be, oh, I probably should stand here so they can see me. Even when you are just answering a question in the pharmacy, that would be a key thing just to make sure that they're not on estrogen, right? So, okay, they're on a progestin only, so that's appropriate. So yes, we would tell her, take your pill as soon as right now, that's totally fine. If you do have any sexual activities in the next 48 hours, just make sure to use backup. That's it. And then tell her the 3-hour window and you're good to go. The drospirenone is how long? 24. So 24. So if it was drospirenone, she wouldn't need to use backup. My other question. So we have a patient on low estrogen FE. She experiences breakthrough bleeding in the first week of her cycle, and she's had this happen for the past 4 cycles. So what are we going to do about this side effect? So our options were to switch to a medication that has higher estrogen, tell the patient that we typically have to wait 6 cycles to make sure that it's just getting used to the hormones, or switch to norethindrone, or switch to non-hormonal. I made my questions really hard to make you guys think. So let's break it down. Breakthrough bleeding in the first week, is that estrogen or progesterone? Estrogen. And then is it too much estrogen or not enough estrogen? Not enough. So she's on low estrogen, which is usually a 10 microgram. So you can switch to low estrogen, which is a 20-25, I think. And you'll hopefully be able to decrease that breakthrough bleeding. And then she's 4 cycles. So how long would we take to make sure that 3? Yeah. So we want to wait the 3 cycles. So she's at 4 cycles. So most likely we need to adjust. My last question. Oh, my last question. Oh, they're not bolded anymore? They're bolded. Oh, did you unbold it? No. I don't want everybody to know the answer. Okay. So my last question is very long. We have a patient who's 36 years old. She was previously on Yaz. She stopped it about 9 years ago. She has past medical history of seizures, breastfeeding, smoking 1 pack per day, and anxiety. Her medication list is sertraline and levetiracetam. So what are we going to initiate? So can we initiate Yaz? I see someone going no. Why can't we initiate Yaz? 36 and smoking, and also breastfeeding. So we already know we can't go forward with Yaz. So yeah, she's currently breastfeeding. I guess I should have said current breastfeeding, but either way, the smoking 1 pack per day and greater than 35 would be not using Yaz. So then now we're thinking, okay, do we go progestin only or do we refer? So progestin only would be okay if she didn't have the seizures. She's not on any seizure medications that are CYP3A4 inducers. So levetiracetam is probably the best one for a patient to be on that we could refer for. My thought with this would be, we would probably want to make sure that she's not going to be initiated on anything and that her seizures are controlled before we would start another medication and that could possibly interfere. So to me, if I could get in contact with the neurologist, maybe we could do that. Most likely we do not have time for that. So that would be a referral to make sure that seizures are good and that this would be okay for the patient to be initiated on. So that is my presentation. Hopefully, oh, I wanted to give you guys this first. So this is a lot of information. I'm aware. Different resources that have been really helpful for women's health practitioners is the contraceptive technology book, which is a little bit outdated. Same with the Richard Dickey book. Both of those do have really good lists of medications if you don't have access to pharmacist letter, besides what I provided for you. The other option is Birth Control Pharmacist is a website that has a lot of CEs and a lot of resources for starting a pharmacist prescribing in the pharmacy. And then there's also a free app from, it says I'm muted. Is that bad on this? Can you hear me? Okay. There's also a free app that has the US MEC on your phone. And then this SPR is Select Practitioner Recommendations or Select Practice Recommendations. That is the CDC recommendations for prescribing birth control. So both of those are free that you could have on your phone. For patients, the Planned Parenthood has really good pictorial for patients if they have issues with administering, and also just really good education. And then the birth control pharmacist does have resources that you could provide to patients. So now I'm really done. What questions do you guys have? Yes. Question was how long to have a pharmacist allowed to do the intake. Hopefully a lot of this information the patient can fill out themselves. I didn't include, I use activities for my students. The birth control pharmacist has a screening document. I didn't include it because I anticipate DCP is going to have their own, but hopefully a lot of that the patient will fill out for you and you just have to follow up with information. So you're going to get information about weight, their social history, their past medical history, if they've been on anything previously. With that, I would still think about 20 minutes, depending on how much administration they're going to have to give. That counseling could take a little bit. But once pharmacists get used to it, it can be more efficient, but you still want to make sure you're doing it safely and making sure the patient's going to be using it appropriately. So the question was, the COCs always thought was 1%, but I presented the 7%. The 1% is perfect use. The real world is the 7%. Patients forget to take their pill and then they don't know and then they forget another one, things like that. So that is typical use efficacy. The IUD and the subdermal implant have that 0.4 to 1%. So they have the highest typical use efficacy. What other questions do you guys have? I'm sure that was very overwhelming. If you guys have other questions, I'll be here all day to answer questions. Thank you, everybody.